Hello, Move Better, Feel Better, the Feldenkrais Awareness Summit. I'm Cynthia Allen, and we're in the research track. And before I start that, I just want to say that if you haven't thought about upgrading to the unlimited digital access, I highly suggest you do, because there are incredible opportunities to listen to all of these talks, as well as some depth bonus courses, actual live courses that'll take you deeper. And so if you haven't checked it all out, do that, because while the summit is happening, you get a discount. Once the summit is over, the discount goes away. So go ahead and check it out. And I'm very pleased here to have today with us Tim Sobey. Tim is a physical therapist. He is the founder and clinical director of Alliant Continuum Care in Tahoma.
Tacoma.
Tacoma,
Mhm.
Tacoma. Gig
Southeast County.
Yeah, Olympia, Washington. He has over 35 years experience as a physical therapist and over 25 years as a Feldenkrais method practitioner, and he's a native of the state of Michigan. He earned his bachelor's of science in physical therapy in Oklahoma City, and then went on to complete his Feldenkrais training through the Movement Studies Institute of Berkeley, California. He earned a master's of science degree in behavioral medicine, and I think that's one of the things that makes him interesting, is how he's continued his work since becoming a physical therapist and a Feldenkrais practitioner. And then he actually went on to complete his psychology, his PhD, his doctorate in the evolving field of clinical psychophysiology, mind, body medicine, and biofeedback through Saybrook University in California, in Pasadena, California. He's also done whole systems design study at the Antioch University. So, wow, what a big, wide range.
Yeah, and it never stops.
Tim,
Hmm.
can I add anything else? Can I put anything else in there? Can we throw something
Well,
else in
well,
there?
just this being 2021, it's interesting to note that 1991 was my segue, I guess, of applying to a Feldenkrais training program, and that was the Oregon, Eugene, and Portland program from began 92 through 96. But this marks 30 years since being in contemplation of taking a training, and that created all the academic research is attributable to Feldenkrais method, uh, attempting to be understood for between disciplines and further research.
Yeah, and so you've had an interest in virtual reality, augmented reality. So I don't know if that means we're going to all get to put on glasses and experience the Feldenkrais work through virtual
Yeah.
glasses. Is that what you're into?
Well, interesting. I'm really not, had it not been for graduate school, I probably would have been a technophobic person. But the idea of augmented reality and virtual reality came about by way of using multisensory images to convey a sense of anatomy and sense of movement to patients who, as we'll discover, clients have poor sensory representation of their anatomy, particularly with chronic pain. And so it was called body schema acuity training. But as I looked at Feldenkrais experience, and perhaps we've all experienced this in Feldenkrais movements to some degree. We do a sequence of movements on one half of our body, say. We lay on our back. One half of our body feels like a Picasso painting, all maybe expanded in some places. The other half feels maybe contained and shriveled up. So that hemispheric difference to me was quite surreal in nature. And so when I began to look at headings about virtual reality, surrealistic experience, even surrealistic art like Magritte and others, that sense of surrealism has always been what's attracted the Feldenkrais experience for me. And so I began to look at features of virtual reality and augmented reality. And so augmented reality is really the place for what I'm doing and what I want to develop in the future. I'll just need some technical partnerships.
Yeah. So you're going to take us on a little journey here, understanding some things about back pain, chronic pain, and that's a
Yes,
topic that's certainly near and dear to my heart and in my practice. And then how you have not only what the research is that was existing, but how you have added now to the body of research through your dissertation. So let's let you kind of jump into that a little bit.
great, great. So I can maybe shift the screen share here. It looks like I'm the presenter with a yellow window around me. So this idea of reframing body schema in chronic pain, especially in low back pain, and looking at augmented reality, skeletal density imagery as a way to augment Feldenkrais experience. And so Alliant Physical Therapy is my practice. Body Remotely is my online venture now. And so this material from my dissertation has been presented nationally, internationally, locally, within our field and outside our field. I felt really privileged to be able to travel to Europe in 2019 before the pandemic for the World Conference of Low Back and Pelvic Pain. And I discovered even between disciplines, there's still interest in Feldenkrais method. It's just more awareness needs to be created, and that's one reason to do research as well. And so let's go ahead and look at the idea of how we'll present this presentation. Because of phenomena, the experiences we have, and then research is a way of maybe quantifying or qualifying just a small segment of our experience, which I found to be the biggest challenge in Feldenkrais is how do you condense this, this multi-dimensional experience over the course of 4 years into a research study. So I find that, for Feldenkrais practitioners and maybe audiences who work with patients and clients, practice-based evidence accrued through daily work maybe develops the clinical questions. And maybe evidence-based practice is something that can help inform that. But by and large, I think experience precedes discovery. I think art precedes science in lots of ways, in some form. So this problem of chronic low back pain, where do we stand? How do we stand might be another question, right? But the idea that there's all kinds of statistics online, even with chronic pain in general, 30% of the United States population is in some kind of ongoing pain state. And that's the Institute of Medicine quoting that. Second most common cause for sick leave and disability, $86 billion of incurred costs in the industrialized world. 50 million adults have chronic pain. And for research and clinic practice, it was the bulk of my patient caseload was some kind of a low back spine condition, neck or back situations, right? And we look at the broad range of treatments applied to low back pain. Chiropractic comes to mind often initially. They've done a very good job of compartmentalizing subluxation, acupuncture, massage, pharmaceuticals therapy, electrical therapies and surgeries, meditation, mindfulness, and then of course, back exercise is something active is most commonly recommended as a way to help resolve chronic persistent conditions. But some history of the past, again, this has been going on for quite some time in even our ancestral history, however form that takes. And looking at physical therapy in 1980s, when I graduated, the big topic of certification was spine mobilization. Vertebrae were stiff. You had to mobilize them to get them moving to get pain-free and stretch. And then in the 1990s, oh no, wait a minute, these muscles are protecting and tense because the segments are too unstable. And the muscle activities co-contracting to protect and isolate and prevent inflammation and shear. And so you got to stabilize muscles at the core, which surrounds the spine column. But for the new millennium, beyond the 90s into this, was it 21st century, the 2000s? Physical therapy, maybe spine organization is something to look at. I looked at Google Images to say, okay, find images for spine organization. Unlike the previous decades, no images could be found with that topic. So we needed to change that. And I believe our Feldenkrais work helps bridge a gap that direction. And yet, you can look at any outpatient physical therapy clinic in the United States, Canada, Europe, and world and discovered that people are practicing core activation as a treatment of choice for low back pain, chronic low back pain. And over the recent years, say early 2000s, E.L. Lederman, a professor at UK, osteopathic physician as well as a physio, had a landmark paper I consider, The Myth of Core Stability, which brought the standard into question. And the International Spine and Pain Institute hosted him. I was privileged to meet and hear him. And even in Physical Therapy Journal more recently, we're beginning to look outside this reductionist structural biomechanical model of implicating an anatomical cause, which, as we know, symptoms can occur independent of structural pathology or not correlate to it. So I really appreciate this. Renee, I'm not great with French, Peteler, I tried, who is in Montreal, who published some wonderful papers about neuroplastic changes and central nervous system being a missing link for understanding chronic musculoskeletal pain. So even as a Feldenkrais practitioner, the continuity of the skeleton is just something more substantial than core. Again, this is something I drew up early on to look at a pilot study that, okay, here's this isolated region, the back, focal application. And then the idea, though, is we treat something that's painful, it reinforces maybe everything associated with that pain. So how is your back today? There'll be associations that go with my back. Don't think of an elephant. The elephant appears in the room, in the person. So perhaps there's regulatory variables above and below the core. Feldenkrais being based with systems thinking, that tends toward distributed application, looking at peripheral relationships above and below the back that are not the back, but likely affect the back. And looking at functional relationships, I love how Shahava Shalhav and a co-author, Delaya Galum, wrote an awareness to movement that a Feldenkrais lesson is structured around a particular function. He did not deal with movements specific to a part of the body, but rather a function and its components, which involves all of ourselves. And looking to kind of reduce Feldenkrais method to research posters, not in essence of application, but in written word. My take was that Feldenkrais practitioners, our work aims to create individualized multimodal learning experiences that clarify awareness of new functional interrelationships in both perception and action within the cognitive construct of one's own body schema. That's a lot to take in, but that's the expansiveness of our work. It's always hard to consolidate in verbal language and concepts. Experience actually does better. And I found that out when I went into the training with chronic heel pain and back problems. And I'm working with my head, the Feldenkrais trainers and guest practitioners. It didn't make sense to me as a physical therapist. What do you do with my head and shoulders, my problems in my heel? Well, we'll learn more about how that works. The distortion of body schema is something that's been researched through a pain researcher in Australia, Mosley, Lotz and Mosley, that there's evidence of distorted body image with persons in pain. Their sense of arrangement isn't accurate to how they move. And this can be verified with corresponding imaging on functional MRI exams and findings in the clinic. And so the somatotopic map, the body map on the brain, undergoes reorganization, distorted neurological representations of our body in response to conditioned states of chronic pain. And this happens on cellular level as well as, say, functional connectivity levels between brain regions. And the body map in the brain is something quite fascinating to me, and how pain is co-conditioned with movement limitation. Movement limitation prevents our exploration, our sense of safety. Emotional centers begin to take over for movement centers, is what's evidence showing. The default mode network at rest in patients with chronic pain. Default mode, maybe just for simplicity, is everything that's going on beneath our level of consciousness that keeps us conscious. Our baseline physiological brain activity, default mode network.
Tim, did you say that? Tim, did you say that the emotional centers take over for the?
Well, yeah, there'll be some demonstrations of that too. That is the limbic system and its components become hypersensitized and when we go to do a movement test, that area is lit up on functional MRI. I'll be showing you some slides with that real soon. So default mode network, it means when people are even at rest, accessory brain activities and pain are overactive without doing anything at all. But it's interesting is the visual network under chronic back pain is actually lower activity. So it's interesting, like I'm so frustrated I can't see straight. Maybe there's something interesting about that. Our sense of vision and imagery might be reduced in these states. And so the study by Vrana in Switzerland, I loved. When people are in pain, there's apprehension of experiencing pain again, fear, avoidance, anxiety, kinesiophobia, fear of movement. And it's hard to maybe see what's going on in the brain if you're in an MRI chamber because movement creates artifact distortion in the imagery of the technology, the resonant waves. So she and her team had this clever idea of having people imagine, look at visual slides inside the MRI chamber, laying there, and observe people doing movement tests, which you see as photos on the left. And when people did tests that looked like they would aggravate a back condition, persons in the pain-free control group that did not have back pain had, efficiency of use of self just to execute the task. That's this brain scan on the left. But the brain scan on the right, there's excess activity happening in order to just accomplish or imagine accomplishing, just imagining accomplishing movement tasks that involve potential back strain. And a lot of these are limbic centers, thalamolimbic centers, having to do with the sensory and emotion processing. And they go into more detail here, which I don't want to do too much. It's supplemental motor area for feed-forward control of anticipated front movement is disrupted. Superior temporal gyrus, sulcus, having to do with a sense of body orientation in space and matching sensory inputs with internal movement representations. I call that working body schema. That's disrupted. And then enhanced functional connectivity, I had to kind of help grok this a bit, but the motor imagery network was really divergent and extraneous and projected to areas that weren't necessary, maybe parasitic movements, right, in regard to that activity. So they had an enlarged need for neural resources beyond usual sufficiency. And so that's evidence of differential neural processing during motor imagery tests and chronic back pain. So again, with Explain Pain being kind of a landmark book, there's this idea of body smudging, that we don't have a good sense of ourselves, therefore maybe more vulnerable feelings, more pain. And they've outlined maybe grids on persons' back, where they had persons lay face down on a table with a window, and they would touch an area of the back on a grid. That's what these number representations are about. And then they'd have the person mark on a diagram where they correspondingly thought they were touched. And persons with chronic low back pain were vaguely unclear or not accurate. So Mosley published that paper. I can't find it. There's distorted body image and tactile dysfunction, not having a sense of what the grid looks like on your low back. But beyond that, and here's where we get to an experiential situation, the sense of our deep articular joints in our body and how we function and move is something I find more interesting and more functional than just outlining a grid on the back for tactile representation. How about sensory movement representation? So let's experience an experiment. And how awareness inquiry, number one, is our primary support function. What I'll ask you to do is stand up, lean back. And so those of you in the audience can get out of your chairs, which is a great idea anyway, if you're seated, and step back a bit. And now with precision of 2 fingers, that diameter, can you pinpoint your sense of your hip socket, central axis, with anatomical precision? Somewhere between your ribs and your knees, let's say, is your hip sockets. So use your fingers and touch yourself where you think those might be, wherever you think. I'm kind of, creating variety. So everybody have a spot, right? And pinpoint with 2-finger precision, please. So it's a little bit more specific with self-touch. And so once found, stay there. What I'd like you to do is kind of walk around, maybe bend around with your fingers touching yourself that way. And notice what you've done. And so if I go back to my presentation here, again, this idea, I kind of have the hidden dimension of where things might be. I cover the anatomical area, the place where you support yourself. And most people, about 85% of people, tend to put their hands somewhere on the periphery here, somewhere where the handle bones of the pelvis are. But that's not really where the hip sockets are. They are really below this level. And if I step back just a bit, I can demonstrate something here. There we are. It's like that's in our groin socket. And what's really interesting about that is that if I look at the width of eyeglasses, and I got these kind of colored glasses that can show up a bit more, but if I place these glasses on, say, the width of my eyeglasses, these are from the 80s, right, to this level here, right, it's the width of socket to socket is this wide, yeah, about as wide as our head, not this wide outside our body in a sense, but inside, right? And so that's something that we'll go to the next slide. Maybe 3% of persons might recognize that it's deep in the groin socket, the pocket. And so hip joint 101, where do we sense ourselves that way? And so when I show people this idea that the width of the eye sockets is the same width as the hip sockets, they're pretty amazed. And Feldenkrais wrote that hip joints seem non-existent. The awareness of hip joints, rather, seems non-existent in Western cultures, completely out of place when locating them. So it's a mislocalization. And we use our legs as if they're articulated in imaginary areas. And this disparity seems to matter. And so distortion of body schema, this is a patient of mine who demonstrated after recurrent injuries, touch where your legs attach to your body, you'll notice her fingers are in separate places between left and right. And she believes in her consciousness with eyes closed that her fingers are in the same exact place. But no, they're actually quite asymmetrical, as you can see. And virtually all back patients are less than accurate with distortion of this. And it doesn't necessarily mean this causes back pain, but there's something about this that the greater chronicity of low back pain, the more profound the distortion of inaccurate hip socket localization. This person has her legs attaching to her mid-thigh even, just even way down here. And she believes that's where she operates from and walks from. So you can imagine how that schema might affect quality of movement. So they get revealed in 3-dimensional planes through some hands-on use of model bones. This is an augmentation of sensation, so an augmented reality of sorts. And the internal rotation happens much easier, gait, balance, quality of walking. Those of you who touched yourselves on these outer areas or someplace else, if you put your fingers the width of eyeglasses at your hip sockets, and imagine they're not in front of you, not behind you, but within you, right? Kind of, perpendicular front to back, outside in. And feel where that is and imagine and walk around from there or bend from there. You'll feel a bit more robust in your support. And so this reminds me of a popular quote used by therapists of all kinds. Mr. Duffy lived a short distance from his body. James Joyce, poet from Dublin, Ireland, but it applies to our sense of ourselves. So, but I had a concern. I had a concern about persons locating at the hip sockets. If they did that only, would that become a new habit, right? Would that become something to hold on to too much? So I dug deeper and looked further and thought that maybe there's another level. And this was informed through, I believe, your keynote speakers, Olena Niederfor, Cynthia. So I attended a Seeing and Sensing the Skeleton workshop back in the Feldenkrais resources in Berkeley. And she had outlined this idea that this pectineal line this inner ilia bridge was the densest bone of the body. We were doing like bridging movements to kind of get a sense of it. But I've since sort of done some hands-on manual techniques that is sort of, it might look like deep iliopsoas release and massage therapy and body work, but it's not the psoas I'm concerned about. I'm concerned about conveying an inner bridge in a person. And with imagery, I take maybe my clinic flashlight. I don't know if this shows so easy or not, but you see that something shines through. It's kind of an opaque image of what shines through here. But if I'm in this ilia, look, you don't see the light going through. So there's a denser, this inner bridge of the pelvis that goes through. It's almost like a vortex funnel that broadens into the front of this sacrum. And you almost feel like this ring goes across midline. And so there's some examples of that I do more in an advanced training. But I showed you already. But the idea was, could we reframe a connection between hip socket and low back? Not to be called small of the back, but top of leg. Maybe the low back, there's horse hips, right? We don't call horse hips low back. We call them robust legs in a horse race, right? And the image of the pelvis, there's the light passing through it. And so not the outer shell, but the inner ring of the pelvis being highlighted as a robust sense of core density, shall we say. And so this evolution of becoming upright, these Nick Beasy radiographic photos are fascinating. You see how the inner ear, temporal bone, that the inner ear is the densest bone in the entire body. But then the idea that there's a little bit of denser white, indicating denser bone tissue, is in the low back pelvis as well. And then the pedicle chain, where vertebrae attached to ribs. Yeah. So how could we operationalize this in standing and walking? There's some more imagery I use where Christopher Powers, who's at USC California biomechanics lab, physio PhD, had this Vicon polygon viewer where a person would walk across, the camera would take a picture of them. And I took still photos for my dissertation anyway to show what was happening. As stairs, when we take our first step, there's a ground reaction force through the skeleton, not outside the pelvis, but again inside the pelvis is how it's reflected. If I turn the person from side view to front to back, well, you can sense that the slant of the vector goes opposite side. So the circle can be construed as the left inner ear temporal bone, as a region of higher bone density. And then as we step through and push off, the vector isn't quite as high compared to high point of the hip. It's more less robust because momentum is carrying us forward. But if we look at the line in the front plane there from this model, it's straight up, maybe the corresponding ipsilateral same side of the inner ear up the chain. And so we combine that with avatar images. There's a mobile image of this horseman walking. And I created this whole idea for session 2 in therapy that says, okay, I showed you hip sockets last week, but I don't want you to be stuck in hip sockets only. Maybe there's more to the legs back connection. Let me be a special effects movie maker, technician, and you be the actor or actress. We're going to sort of connect horse hips to your body. And so we created this whole scene where they were like an action superhero avatar galloping up this mound to kneel on it. And when they kneel to their knee, they get this pathway sense of inner bridge of pelvis through the spine to opposite head. And that's kind of the maneuver there, the head counterbalancing potentially. And then we take it to walking, where a person, interesting enough, I got a deer horn from an antique shop. Something about it felt just right, like a nice organic art with density in it. And I used that to put on people's heads with their consent, of course. But as they would walk, they get a sense of how, rather than call this small of back, call this top of leg inside. And then have the other end of that, be here, would be a way of conveying a sense of pelvis through spine to head. So that transmission of skeletal forces through the body. And so and our skeleton fellow here. So if you take a step, stance stays through here, up across, inside the spine column, and through the skull base. Yeah. And so I have a life-size skeleton that we would use to feel and outline all these dimensions through touch. And we could actually take a break for a moment and just feel how you could connect something like that. Hip sockets was sort of phase one of an idea, an image to convey. But the next time they came in, no, wait a minute, maybe there's more to that. Maybe this isn't the small of your back. Feel how small this is. Oh, the small of your back. What a vulnerable idea. Instead, you take organs out of this pelvis, you reveal this inner bridge that we demonstrated is quite dense. And so having a sense of maybe hip socket where we left off in the front, but then what people call the small of the back here could actually be reframed as a top of leg. And so if a person has say a problem on the left side, which I'm demonstrating, or you could do your right side in reverse, but just for sake of interest, let's go ahead and do the left side for uniformity if we could. Place your left hand on the left, what people call the small of the back, is actually the top of the, the sacral joint area, right? Where people kind of go, oh, I stepped off the curb and ouch, right? And then there's this inner bridge where the socket is, but if you stand there and have a sense of what's inside that bridges those two, it's a real deep awareness. So just standing there on two legs, could you very slowly, gently float or raise your right heel off the ground? And you'll find that by elevating your heel, the left leg comes to service to you, to stand over, for you to stand over your left leg. And now while your right heel is floating, could you rudder your right heel outward toward the wall or reference that's to the right of you? So as you turn your right hip socket inward, or your pelvis goes with it, you'll see that your whole body turns to look at the left side of the room. And while you're doing that, you could almost imagine a sense of this inner bridge going from hip socket up and through to the top of your leg, where your left hand is behind your back. We'll call that the inner bridge, the balcony, yeah? And then as you come back, let your right heel swivel back, still holding on and referencing your left side. And return your heel just for punctuation, yeah? Pause a moment. And now raise your right heel again. And feel how your left stance just becomes available for you automatically. And now while you're here, rudder your right heel inward toward your left ankle. And there you might notice that your vision, hopefully your eyes are on the horizon, can orient to the right. And as that happens, have a sense of this inner bridge descending down to where the hip socket meets inside. We'll call that the orchestra pit, or the first few rows. And so what I'd like you to do now is go both directions. Let's just pause a moment in the middle just for return your right heel to the ground. Just start in the middle for a moment. And now raise your heel again. And now as you rudder your right heel outward, turn your torso and vision gaze horizontally to the left. We'll call that the balcony, where your top of your leg is your spine column meets the top of your leg, if even then. And then we'll call the middle zone, the mid zone, kind of the middle seating, the mezzanine, the main seating, yeah? And then rudder your heel inward again, down and forward. We'll call that the orchestra pit. If you go back and forth this way and begin to reduce the movement to arrive in a neutral place that's not the balcony, not the orchestra pit, but maybe a neutral mid-range maximum ease, a place where you can go forward, down and forward, or up and back with equal ease. Stay there a moment and take a breath and just settle there as if to drop it that way, yeah? And then just go ahead and let your hands rest, let your heels rest, and just notice the side that you were kind of outlining internally. Having a real skeleton helps. You might feel if you shift onto it, just feels a bit more supportive if you were to do Tai Chi or stand or step off something. Compared to the side that you didn't touch, you might feel kind of downhill on that side if you shift right. perhaps, yeah? I myself feel upright here and feel kind of downhill here. I need a refresher on this side, but maybe later, yeah? And so I actually had a sciatic symptom, J.C. Penney, after the Seahawks won the Super Bowl back in 2014, where I felt like my leg gave way and I didn't know what to do. But that resource of this inner bridge came to me. And I found this inner bridge, this inner lattice work that diffused the sciatic symptoms like automatically. And I was able to, walk out. There's a little bit of residual and stuff, but it made a nice difference. So augmenting the vision, becoming a centaur, that's part of the story I give people. It's been so long since I practiced this hands-on, since the pandemic, but be the centaur that you are. We went from low back pain patient to avatar superhero, half human, half horse, in some mythical place, right? So this idea of a deeper, denser core, the inner, pelvis bridge, and the temporal bone of the inner ear have an interesting anatomical relationship beyond that. And there's another way of locating your inner ear. I don't know if we really have time for that, but it's a way of looking at persons referencing where is the inner ear inside the body. These three loop structures are beautiful, these semicircular canals. And I'm devising an ergonomic program to harness these structures as a way to orchestrate your body space in a workstation sitting. So do we have time for an experiment? We could always just invoke this one for this. Let's do a third part, why not? So let's do a range of motion test first. The therapy or doctor's office says, okay, turn your face to the left. Notice the last object in your room is a reference. That's how far your neck range of motion is as an external reference. Feel that maybe it corresponds with muscle tone in your neck, stopping without stretching. Okay, great. Come back to neutral, or starting place rather. Neutral, of course, is an evasive thing or accommodating thing. Yeah. And now turn your face to the right to orient the world to the right of you and notice maybe it's easier, maybe it's not. For me, it's not as easy. Now I could stabilize my core muscles and pull my chin in and activate my abdomen and stretch my neck to get more range of motion. Of course, that seems to interfere. Or I could look at something that's not related to muscle activity directly at all, but neurologically quite directly. So let's do this experiment. I'm going to use my right side for the sake of this one. Could you place your right finger in your right ear and then have your left index finger point straight into your right eye? If you have eyeglasses, you can always opt to raise them on your forehead and have the front finger, your left finger goes, imagine you have a laser beam in your left finger that goes front to back, out the back of your head. Of course, your finger in your right ear goes through your right ear, out your left ear. And close your eyes a moment with your hands referencing and imagine that where your two finger beams, your laser beams from your fingers meet inside your skull, are the anatomical location of your right inner ear organ. And visualize inside there may be a miniature Ferris wheel that goes up and down. That would be your vertical canal, one of the loops, one of three. And now imagine adjacent to that, there is a horizontal loop, like a merry-go-round, that rotates around you like a merry-go-round. That's for eyes counterbalancing opposite, gaze stabilization, vestibular ocular reflexes, things like this. And now imagine between the Ferris wheel and the merry-go-round is a tilted Ferris wheel, diagonal. And that would be going, say, toward the top edge of your head. If you had a square head, it'd be toward the corner above your right ear. If you had a flat head, it'd be where the ridge is, yeah? So you kind of orient that direction for side tilting movements of the head and torso. And now just visualize all that. And now just let your arms rest by your sides. And just have a sense of how your right shoulder feels or how your sense of space feels to the right of you. And now place your right finger in your right ear again. And this time with your left index finger, could you place that to the inside corner of your left eye, where the tear duct would be. This is the opposite bridge of your nose, right? You're behind the left bridge of your nose in the left inner corner of the eye. You can touch gently if it helps, or just be on the threshold of touching. And now from here, connect the finger beams, imaginary laser beams of right fingertip and left fingertip together into one beam. And that orientation is how your inner ear organ and temporal bone are aligned and situated and oriented inside your skull on the right side. And if it faces outward, it'll feel crowded if you face inward. So it's kind of opposite of horse blinders. You're able to navigate the world. Yeah. So that's the orientation. Keep your finger there and bring your finger back to the front of your eye. Your left finger in front of your eye again, and your front of your right eye. And just sense the location. Okay, and I'll let that rest. Let your arms rest. Again, if you have a shoulder problem, you can always rest early. But notice the whole right side of yourself, and now just recheck movement to look right. You might notice some of you probably go quite a bit further. This is kind of the thing we do in Feldenkrais with the arm a lot, right? To demonstrate stuff. So what's fascinating is we didn't stretch muscles, we didn't manipulate joints, but we got easier movement, right? And so there's something about the inner ear and where it's located as a reference.
But there is a difference in that, in what you just did and what we do in the Feldenkrais work.
Okay.
In that you're highlighting, you're somehow highlighting, and even in my imagination, which I'm very poor at, bringing that concept of those lines. But you brought my sense of myself very interior to converging. Converging planes of motion.
Yes.
Which is very different than we would do in Feldenkrais, which we would, as you know, that's it may accomplish a very similar thing, but I love that. I love this.
Well, thank you. Thank you. You're right. I mean, that's something that, again, as an early practitioner, having a wonderful table session or giving a wonderful table session, and then, well, what's this all about? I feel, so, the idea of making the impossible possible, easy, elegance, great. I think we had to need a fourth dimension to that would be, can you make the intangible tangible? And my feeling is that the virtual reality.
I love that. Make the intangible tangible. I love that.
It's such a challenge to explain our profession in the elevator conversation, which Goldfarb references a lot, and all practitioners reference a lot, how to articulate it. But experience is best. And when we get to the research, you'll see why I included these bones to make something tangible in the Feldenkrais experience. Yeah, something apprehensible, perceptible. Yeah. So, and then look at this. When you line up the inner ear behind the eye, inside the ear with the, I'm pointing at my screen like it's there. It is there. But the inner bridge of the pelvis and the hip socket where it articulates deep in the acetabulum socket are all one vertical line in the standing skeleton.
Okay, and that is just cool.
That is cool, isn't it? Yeah.
It's just cool.
Yeah, thank you. And then so you can think of the pelvis and hips as the center of gravity, right? But then the inner ear as detection of change. How do you orient this in the camera? Detection of change of center of gravity, right? So what was interesting beyond that, just sort of the intuitive science, is I measured these bone density regions. You take off the cap of the skull and look inside, you'll see this dense ridge, the temporal bone, which I put blue painter's tape on. And it's 3 centimeters in width, encasing the vestibular. You look at the inner bridge of the pelvis between, hip socket and base of, say, sacral. That's 9 centimeters. That's the densest bone that Alina informed in the lower body. So upper body density, lower body density. We talk about proportionality and movement a lot in Feldenkrais. For research, how do you quantify that or articulate that? So what I discovered here is, let's just call this proportionality of thirds. If your pelvis moves 2/3 and your head, if your pelvis moves 2/3, your head moves 1/3, there's a certain uprightness that goes with that. Modern life is kind of inverse of that. We're sort of forward doing stuff. Our body's outside our base of support more. Try to move your pelvis, it just seems hard to move underneath all that. So that proximal initiation of movement is sort of a rule people can be taught to follow. Move your pelvis 2/3, counterbalance your 1/3, take that with you, just as something handy. So we decided to test this. It was sort of a routine practice that was going on, say 2013, 14, that period of time. And we did a retrospective study of looking at persons who were treated and looking at, in the records in our charts, multiple single subject design, 3-part body schema model, hip socket, inner bridge of the pelvis, inner ear. And the mean age is mid-50s, right? Common age group that I see. 30 female, 10 male, still kind of common, right? So, day 1 was pinpointing hip sockets. Day 2 was reframing the pelvis plane as the inner bridge of leg support. Day 3 was correlating the vestibular apparatus through what you're talking about, interoceptive imagery is kind of what I'm calling that here. It gets so many names. But what's interesting is for low back pain, there's no attention given to isolating lumbar spine segments directly. L1, L4, L5, none of that's ever talked about in my treatment models. And after treatment, people average from 6 out of 10 to 2 out of 10 for pain. And when people have a sense of hip sockets more accurate with head pelvis position, they walk around, especially after hip sockets, you see more of a quality of gait that just flows. Go back to where you thought your legs were more peripherally, you'll see them kind of misstep and laterally displace themselves, being less upright, less vectors through the core of the skeleton for ground support. And often their symptoms will sort of spontaneously reappear, the familiar symptoms, co-conditioned or correlated with the mislocalization of where the hip sockets are. So all 3 of these conditions, of course, were novel interpretations of body awareness. What my hip sockets as wide as my eyeglasses, new revelations for people, which attracted interest and I think creates neuroplastic pathways in the body maps. So these body schema-based somatic education approaches, specifically Feldenkrais method, deserve more investigation. So what happened next? You got to take what you've been doing clinically and compare it against something else to see if it really has a significant effect. And the best thing to do in a controlled study is to compare it against the current standard of practice, this being, as I had mentioned earlier, core stabilization. And so long title, Body Schema Acuity Training, that's what became virtual reality bones later. And Feldenkrais movements, compared to core stabilization, I had to use some kind of a biofeedback to qualify that. And then motor control exercise protocols. Now, when my professor, Dr. Rich Sherman, talked about, you got to get a protocol, I was kicking and screaming. As a Feldenkrais practitioner, with all the creative license that we do, right? Protocol just sounded really constraining. But yet within constraints, you can create other expansions. And so, just getting beyond that, the control group and core exercises, what I found is, adopting a protocol that is holistic systemic is still retaining the Feldenkrais's essence, even though it might be becoming routine. I do the same 4 things with my low back pain patients in practice now before they get turned loose to my physical therapy assistant Feldenkrais practitioners. I've sort of retained sort of a predictable protocol to introduce people to this internal scaffolding of skeletal continuity, then go do Feldenkrais. So I ended up with the hypothesis. Well, after I got 30 patients, I guess this is a latent hypothesis. Which works better, body schema acuity training Feldenkrais or core stabilization, motor control, the standard of practice? I have a more detailed study flow diagram that I could show if questions are later, but we recruited about 37 patients. They were randomly stratified according to fear avoidance belief questionnaire, high scores in either aversive to physical activity because of catastrophization or fear of movement or re-injury, that something was wrong, or work simulation activities. If they scored in those 2 subcategories, they were selectively distributed in each group the control group and experimental group. That way, that confounding variable was equally represented in the group. And of course, people drop out of studies. We ended up, though, with 30 in each group to at least get data from. And that happened in 3 phases. There's inclusion criteria in a study. I had a medical advisor, Dr. Derek Scott, a pain specialist who is out of Tacoma in Atlanta now. And he would do the diagnostic categories, or the referring physician would. If persons had a litigation attorney representing their claim, or they had multiple surgical spine fusions, failed spine syndrome, or the red flags, distal peripheral signs of a disc herniation, and bowel and bladder control, or numbness and drop. But of course, they were excluded from participation in the study. These are all pretty standard months back studies. Average age, again, mid-40s, mid-50s between the 2 groups. Body types, genders, marital status, work, anxiety, depression. What was found is a lot of these comorbid, for lack of a better term, representations were pretty equal in each group. But most importantly, after doing the fear avoidance belief questionnaire subscales I talked about here, we ended up with 10 in each group. Control group, experimental group were equally represented. And again, this fear avoidance belief questionnaire is a major part of low back pain research in recent years. And I use it as a stratified sampling tool. All right, so the basic tools to get data. There's the pain scale, 0 to 10. Worse than manageable pain at 10, 0. That was rated. Roland Morris Disability Questionnaire is an assessment of perceived disability and high correlation to fear avoidance, and that perceived inability that something's terribly wrong and I'm very injury prone, this is going to get worse, sort of gets validated in that questionnaire. And then patient-specific functional scale is, okay, what are you unable to do that you used to be able to do that you'd like to be able to do better? And that's more individualized for each patient or client. They'd write an activity like, I would love to sit for an hour, or I'd love to be able to stand and walk around the block. They could rate their level and then rescore. And then those are our questionnaires. Dr. Sherman, my research clinic dissertation advisor chair, asked that I do some kind of objective measure too. And what came in the research literature is that McGill out of, University of Waterloo in Canada, outside Toronto, is fairly well known, in addition to Hodges, where they have, a bit of, let's say, application differences. But in any case, sustained flexion, sustained extension, sustained side bending or planking being timed, the endurance, ability to hold the position, is one measure that's more important than, say, a test of strength for low back pain. And so the data sampling of all these tools happened at baseline upon entry to the study, 4 weeks later, 8 weeks later, that means 2 months of treatment, and then a 6-month follow-up, of which I got maybe a third to half of the participants back. So interventions for the control group, the core exercise motor control, I had to hire and contract independent physical therapists who had experience in this area and pay them. And they were able to administer the control group at an average of 15 years physical therapy experience. And this is what they did. I had a whole CD training program on facilitating proper muscle contractions of anterior side circumferential transverse abdominis muscle group and lumbar multifidus muscle group. And those are the 2 muscle groups that are co-contracted and isolated in a submaximal manner to stabilize the core. That's pretty much the main thing that goes on. And so it's very focal around the lumbar spine. This is a biofeedback device, a stabilizer. A person lays on it. The sigmometer pressure gauge is set at a level where a person raises her leg while drawing their core, and you don't lose pressure on the gauge, meaning you're maintaining the proper a load, but you're also not over compressing to distort and increase. So it's not an excess or a deficit. They're looking to optimize submaximal muscle contraction and get feedback about what that means or feels like. But that feeling is centered around feeling your muscles. Yeah. So there's a skeleton doing it. That's pretty magical, where the bag is placed behind the lumbar spine. And there's Jennifer Yegos, my colleague and right-hand person and practitioner, demonstrating for me. And so 3 phases of the outline were in the manual in the booklet by Jeanette that were consistent with the Queensland model of a core stabilization. Hodges et al. There's a whole reference of literature on that in the dissertation. But the phase 1 is activating a proper contraction and then challenging that just a little bit with heel slides and raising legs. Phase 2, there's more of a static to dynamic motor control progression where you maintain your core alignment and raise more legs opposite sides or plank. And the ground surface is stable while you're doing this, or at least partially stable. And then phase 3, you're on unstable things like rollers and physio gym balls to challenge your ability to maintain your core contractions and not shift. That was the control group, and that's what you see happening worldwide still. I'm not a big fan of it, but I had to keep that bias under control, right? So I didn't do any of that intervention. The experimental group, I was a clinician, as was Jennifer. And we had 16 years of physical therapy experience on average combined, and specialty areas in Feldenkrais training 18 years, and back again. Don't look at the core, look above and below it. And so here's where Alan Questel at a skeletal power advanced training helped really a lot to help consolidate what constitutes a Feldenkrais, an effective Feldenkrais session. So that one was proximal initiation of movement, moving from the center, where we have larger masses. How does that contrast with core? Proximal fixation of movement, right? Interesting. Principle 2, mobilizing the hip joints. That's where we went ahead and articulated these, yeah? Principle 3, freeing the abdomen. When I do that maneuver of sort of bridging and leveraging the sense of this inner bridge, being a centaur movie star, adjusting their horse hip, there's a sense of, I ask people to voluntarily contract their abdomen while doing it, they see how it interferes. Distending the abdomen, it's like the hip, the pelvis, the spine, all line up. Then we counter-rotate the head, opposite direction of where the pelvis is rotating, and the inner bridge of the pelvis on the right, say, corresponds to the left inner ear. And then when they lay down and extend their legs again, the whole right side feels just proportionately larger. You do a skeletal transmission through the footboard, board on foot maneuver or something, there's so much more dexterity and sensory feedback and resilience being echoed through that spine chain, or through that skeletal chain rather. You go to the side that didn't get the treatment or the exposure, it feels hung up. Typically where the low back, and where the hip socket meets the pelvis is where it feels hung up. Then finally, relating head and pelvis, principle 4 together. And relationship, that's proportionality of thirds. Then part 5, have it applicable to daily life. Something relevant, not just routine. And so we talked about pelvis, hips, opposite head. This is the crux of, I guess, what virtual reality bones, augmented reality is all about. Visit 1, you identify the hip sockets, you walk on stilts. There's a manipulation maneuver, superimposing the femur bone on the hip socket while doing the manipulation and referencing the head. Visit 2, wait, maybe there's more. Can we connect the inner bridge of the pelvis from hip socket to spine column through the head? There's a centaur, there's an avatar. Part 3, can we look at where costothoracic ribs have holding patterns? Can we do something there to maybe free up the pelvis-rib relationship? Again, ignoring lumbar spine. And for that, I use Ruthie Alon's 3-year back program. it's a session where you have a towel behind one side of your pelvis and you leverage up and you have a sense of how the ribs can lengthen. I'm sorry, I don't have the reference number again for that, but it's in the dissertation. And then part 4, we focus on where the inner ear was again. And I give a plug to Annie Tho, my colleague in Seattle, where you can sit over a bolster. And when you tilt your head, you feel the bolster counterbalance. We use that bolster to outline, say, a hip pelvis from behind and within, throwing like a martial arts pointed star, like a ninja. So it's a rotation over a bolster with pelvis initiating and sort of head being the completion. And when a person sits after that, the side that got the exposure feels much more aligned and robust and upright. Again, when the person walks in gait, there's this quality of just being really stacked up on the side that got the stimulus. So that's the skeletal foundation, shall we say. The next phase 2 were familiar Feldenkrais movements, the frog leg pre-crawl, kind of wishbone leg lift. Gordon Brown, my colleague in Seattle, inspired that one. I use ski poles to kind of reference trajectories and rotation and standing. We did some side bending lateral leg lengthening movements. And then kneeling over the table, if it was qualified. If I couldn't do kneeling over the table, I would do a side lying FI. And so that was a way of getting a sense of foundation for the next 4 visits in the Feldenkrais group. Feldenkrais movements had to do with a ground support was the theme of those lessons with development. And then part 3 was more like trajectories through space. Now that you have a skeletal foundation, a ground foundation awareness, can we articulate ways where our head navigates through space with the diagonal flexors? Of course, the coordination of flexors and extensors, balance beam session, the prone leg tilt. And then head through gait, of course, right? Modigliani, as my trainer referred to it. I call it waitress on Mars in my practice. Everybody's got their nomenclature, right? And so these are familiar things that I think a lot of Feldenkrais practitioners might see familiar when they work with their own patients with back pain. The results compiled all together showed, this is raw data, but every score, Feldenkrais group did better. And we did statistical analysis, which is outside this scope. And the graphs are on charts. The experimental group is the dotted line, less pain by the end of phase 3. Outcome for disability, Roland Morris, the experimental group, Feldenkrais group, less disabled, more confident in their ability capacities. Functional scale, getting back to the things you want to do. This is the one positive area where statistical significance was demonstrated between the 2 groups. P-value less than 0.05. Random chance. The intervention has something to do with the outcome, theoretically here. And then the outcome, which is interesting, for some reason, the experimental group is just an outlier of the study, could hold positions longer from the start. But when we looked at those endurance positions between flexors and extensors, that's statistical analysis again. The values showing significant difference in patient-specific scale. But getting back to flexion extension ratios between the 2 groups, what's interesting there is that in the experimental group, 11 of the participants demonstrated a ratio between flexion endurance and extension endurance that was more balanced. Whereas the control group that focused on core activation, though it's not necessarily abdominals, only one person had a synergistic balance between, say, front of self and back of self, flexion versus extension. So it implies that
I just ask a question there?
Yeah.
So you're saying that in the flexion and extension endurance ratio, 11 people improved in the Feldenkrais group?
Yes.
And only 1 in the control?
Yes. And by improvement, it means that that ratio that's calculated in McGill's biomechanics lab is a ratio of less than or equal to 1.5. That's more explained than that. So it means that we're not overactivating our flexors against our extensors or vice versa. I think they gave more credence for extensors being a bit more able to maintain a load, which is more functionally accurate. So that's an interesting thing.
But in your second item there, actually in your first two items on average flexion extension endurance ratio at the top, are those all parts of the final calculation? Or there the control groups look like they did better?
That's the baseline before.
That was the
We
baseline
did,
before.
and
Okay,
that's like
baseline,
total,
conclusion, percentage
yeah,
change. Got it. I'm sorry.
yeah,
Baseline, conclusion, percentage base. Okay,
after phase 3,
I get it.
and the
Well,
change
that
between
still
the two.
seems pretty significant to me. Doesn't it feel like that to you? Because this is not something that you were working on directly at all with the Feldenkrais group.
As a Feldenkrais practitioner, we don't really, strength isn't the priority. Quality of internal arrangement, quality of movement, and the person's desires are ultimately what's in the foreground, right? So I can imagine if I'm in a fitness gym, which a lot of physical therapy practices kind of look like, in the modern world, and I'm there planking, I'm lifting my hips and I'm counting the seconds. I'm thinking, oh, God, there's my quads, up, my hamstrings, up, my latissimus, up, my quadratus. I'm really fatiguing in that core muscle group, latissimus and multifidus. I can't get, I give way, But if I'm a Feldenkrais continuity skeleton person, I can sort of be in a space that says, okay, let's see, how does my inner bridge of my pelvis connect to my, oh, there it is. There's my top of leg, not low back, top of leg. Oh, yeah, there's that space to the ribs. I'll shift this rib a little bit. That feels more liberating. There's my head rotating. Oh, that feels like it goes through my inner ear. I feel more, just more conducive. I'm not thinking about muscle fatigue. I'm thinking about continuity of skeletal chain density being enhanced, and through that, getting a sense of robustness and power and strength. That's my hypothesis as to why something might work on a phenomenology type of subjective level, intersubjective maybe with others, but that's sort of what I'm thinking, in the experience of it all. So that brings us to the discussion, as a segue to that. I compared this study to another study that was done, in Mankato, 2012, I think up in Edmonton, Alberta, or Calgary. But they used the Australian Queensland stabilization model, compared that with graded activity, just being active and progressing your activity. They didn't find a whole lot of difference between core and that. But my experimental group, when I compared they had larger numbers of people in the study. I think, shoot, do I have it listed here? I reference it someplace else in terms of the number of subjects they had. I don't see it here, but it was like about hundreds of participants in that one, and they had a larger sampling group. But the intervention of Feldenkrais showed a magnitude of difference with all the scores. Well, the flexion extension again, like you saw, bigger difference. Time total average for endurance holding, that was larger. But the patient-specific functional scale looked 3.75 compared to 1 or 2, right? Roman Morris questionnaire 7.4 compared to 3 and 4, right? And then pain scale, the difference in pain change, 4 points change compared to 2 points change. So I think there's something pretty significant there too, compared to a larger earlier study, which is what you got to do in research discussion, is compared to other studies. So the big take-home points now, getting to what, I think our audience of Feldenkrais practitioners and body workers and general public might be interested in, is that I look at traditional physical therapy, outpatient clinics, and I see exercise gyms, which have their place for fitness. But when it comes to chronic pain situations, my take is that there's a sensory side of the equation that's missing. We need to build a sensorium beyond the usual gymnasium. It's not about strength and working out. There's something about the body map, the representation of the body, that needs to be revamped. And looking at physiology, neurophysiology of motor control, this internal model of sensory integration, efference copy, who was our Israeli, Yochanan Ryan wrote about this efference copy, and there's another term. I'm sorry, it escapes me. But I researched that based on what he was saying, and the idea that we have an intended movement. There is a feed-forward model that's anticipating what we're about to do. That's co-adjusting in real time as we, reach for something or approximate something. If there's a mismatch, that gets, corrected and approximated in real time based on the internal map of this function I have of picking up a coffee and taking a sip, which I'll do, which I did. But I look at that, and I look at traditional physical therapy routines or corrective exercises, and this is what people are doing. They're getting their exercise prescription, they're going through the motions, and they're projecting what they're about to do and modifying it according to what the therapist says, that's right, that's wrong. Do this, right? Do the exercises correctly. Well, I took a look, and I think I might just shift, if there's time, we can shift different model. But what I put together, I looked at this efference copy of just going through the motions and anticipating movement and changing it in the same loop and just repeating our habits. I thought maybe there's something more to build on this loop model, looking at virtual reality bones. So down in the lower right, let me see, I got a better picture there. The femur bones, the pelvis, the ribs, the inner ear of the skull, all brought the skeleton together. And each of these virtual reality bone references had ways of creating not just an efference copy of action being assessed, but an afference copy, a new sensory loop of a virtual body being, I don't want to say superimposed, but maybe I'll give credit to Richard Corbet in the Seattle area, a trainer. When we do Feldenkrais through touch, the idea is to construct and project an image when we touch with FI. So idea of constructing and projecting an image, putting these bones models on persons, and then having them move with it. It's like there's a learning curve that happens so much faster. And so my sense is that there's an afferent copy that's a corollary resynthesis. There it is. It's corollary discharge is what Yochanan was talking about. Corollary resynthesis of our body schema is getting revamped at maybe a virtual concept consciously, right? But then maybe subcortical, subconsciously, there's a virtual body pathway that's reassimilating all this. And when that image becomes action in a new way, there's a corresponding adjustment of working body schema, a key area of neuroplasticity, I'm saying. And from that systemic adjustment of body schema, there's a change in the feed-forward model. So we go to do our usual activity, we're doing it in a different way. This is what is characterized as second-order change, where, say, with Feldenkrais movements of, okay, here's a shoulder exercise for therapy. Do your flexion, do your extension. Feldenkrais's idea of, okay, well, is there a shoulder girdle rib as part of this? Are the eyes part of it? And all those sensory additions create this thing where our arm actually isn't just our anatomical shoulder, but our whole quadrant and more, right? And so that adjustment working, corresponding adjustment of working body schema changes the internal model of, say, body representation. That in turn gets produced and detected as an output from the patient or client to the practitioner, who maybe makes a corresponding adjustment of positioning this bone reference to feel better or move with it. And so it's a feedback loop between practitioner and client through augmented, low-tech augmented reality models being used. And so that's the conclusion I have. That's sort of my heart of this. Unless there's a change, a significant change within a person's internal model of sensory representation, sensory representation of effective action that becomes expressed and confirmed through new attention to new movement, then there's really no change at all. And again, movement from and Esther Thalen, the action as perception is part of what informs that model too. So finally, just to sort of close in the idea, body schema acuity training became or evolved into a virtual reality. I almost changed my dissertation title with my professor, and he got pretty hard on me. you got to prove what you're doing with the devices. I said, okay, I'm backing out of that. But later, when I decided to call it virtual reality bones, I did some research on virtual reality. This is in the dissertation, but opinions differ on what really is a virtual reality experience. But here's what some elements, criteria of what it includes. One, you get three-dimensional images that appear to be life-size from perspective of the user. This qualifies for that. Two is the ability to track users' motions, particularly head and eye movements. During all these leg pelvis arrangement things that I do with the models, there's always some head movement that seems to kind of reduce the tone in the lower body to allow something to switch on. So the visualization and the orientation of the head seems to matter a lot, along with the inner ear. And then three, to correspondingly adjust these images to the user's display to reflect a change in perspective. Well, that was using these images as a supplement to FI and awareness through movement. The user's display is their own body, not a computer screen. So it's like, and I know now they're doing lots of projected anatomical images in Australia to help physical therapy students learn kinesiology. They have a person in a room, they project anatomical bones on the person, and then the person moves and the students analyze the movement. So something's happening there for the future too. The cool thing about virtual reality bones, it's VRB is like verb, implying action. The connectivity between body regions, vital relationships between. And then part three, the vestibular representation of the body and the brain. I'm just fascinated by the three-dimensional loops. We want to talk about core stability. If these loops inside our temporal bone that are encased completely in the bone were mobile and gyrating around, boy, good luck regulating our balance, right? So I believe these sensory organs embedded in our skull, the vestibular apparatus, are the most stable structures we have for discernment of movement. The structures themselves, the fluids inside and the hair cells certainly maybe get more acuity of information from that. So that's something I put together in time for the last year's Feldenkrais conference in 2019 anyway, in Boulder. I did a little workshop on that. And sometimes augmented reality versus virtual reality, what's the difference? Augmented reality extends and alters one's current perception of the real world environment. That could be our own body, which is happening here and now, compared to, say, virtual reality. It replaces or substitutes a real world environment with a simulated one. You sort of get a constructed world outside you. My sense of augmented reality, it reconstructs something inside you better. And so, but everything feels exaggerated and surreal after these experiences. And that's how I felt after a lot of Feldenkrais sessions, yeah. So that's, again, reiteration. User's display is the user's own body. And the quality of touch, I thought about how we convey a sense of skeletal robustness, skeletal continuity, based on bone density, skeletal density imagery, I was calling it. I thought about all the manual therapies that are certified and trained to diagnose and classify a manual therapy lesion, an upslip, a downslip, a torsion, a facet impingement, all these features that I've spent lots of my early career learning. I retain a little bit of, but there's a difference in maybe not finding a correction of a manual therapy lesion for illness pathology to correct. Like something's wrong, fix it, adjust it. But maybe there's a way of doing manual hands-on touch that teaches, that conveys an awareness of functional possibility, that exploits or highlights or augments the internal robustness of our skeleton's chain of relationships throughout the entire body as a whole. And that's a cognitive process of learning functional adaptation from within through Feldenkrais movements. And so rather than call it SI joint and reinforce the pathology of it, maybe there's a way to nullify that classification through whole body, whole use of self. And so that's the conclusions of clinical relevance, that these appear efficacious, more efficacious than the standard at this early study. I think it's big news that it doesn't appear to rely on treating lumbar vertebrae locally. I mean, that's big. I mean, the whole idea of subluxations and chiropractic and myofascial release of quadratus lumborum trigger points. Maybe when you convey a bridge between your inner pelvis and your head, that muscle tone dissipates and becomes less of a trigger zone. Yeah. And so the bottom line again is that we need more studies of larger sample sizes for statistical significance. There's all that. Maybe multi-site stuff could be done through our Feldenkrais Guild or people who are trained in this to collaborate. But in the meantime, we can just say there's a link to my dissertation that I can always post in the offer, the giveaway, by giving your email and build a list of persons who take interest in this. And other contact information will be there. There's a virtual reality bones box set, will be part of an advanced training. And I want to thank my dissertation committee, Dr. Sherman, Dr. Jim Stevens, certainly well known in our Feldenkrais Guild as a research chair over many years, and Dr. Scott, pain management physician, and all my staff of contract physical therapists and persons in my employ at front desk, and a statistics tutor at the University of Puget Sound, Samantha, for all that part. Yeah, hire a statistician. That's what you got to do if you're not one. All right, so thank you. I'm going to go stop the share here. That's maybe the subtle back. Okay.
Good. Very nice, Tim. You did a good job. So
Yeah,
thank you for really walking us through both what some of the research shows without your study and then what your study suggests.
Mm-hmm.
I'm sure many Feldenkrais practitioners were thinking the same thing when they were working with the Ferris wheels and the convergence of the pencil lesson, of course, where we spin pencils.
Oh yeah, right.
It's definitely the pencil lesson, but it's the pencil lesson brought even more interior.
Yeah. I did the book on foot lesson with another F word, and so I used my dissertation here for book on foot. But each time I tilt and supinate, just not have a level foot, I get contusions in my butt every time.
That book's a little too heavy.
Yeah, it's just too much. Yeah.
You'll have to let go of your attachment to your dissertation.
Yeah, that's a process.
It's cute. I love that. That's very cute. So, Tim, you have a let's see here. Let me get. You have a giveaway for people. Can you describe your giveaway? They're going to click on a link below this video, and they're going to get something very lovely from Tim. Very helpful from Tim.
Yeah. Well, thank you. I want to credit your organization for hosting up some bridges about going from clinical practice to going online during this pandemic time, and that's a whole new world that I think is a big future for so many people to reach more people. And so what I've got from Alliant Physical Therapy is my local practice, but for worldwide reach online, bodyremotely.com is something I took down as a domain name shortly after pandemic and advent of telehealth appointments with my patients. But yeah, Body Remotely.
You just need to describe what you're going to do.
Right.
We've got a link for them below, so they don't have to write this down.
Yeah, we live a short distance from our body. That's from James Place. So what you'll get is an awareness and movement session having to do with anti-gravitizing your spine. You saw the chain of events vertically through a chain. This one has more to do with balancing and counterbalancing diaphragms through the body, not just respiratory, but say thoracic outlet, occipital cervical junction, pelvic floor. And it's very accessible for persons who find themselves in pain anywhere. You lay on you walk, you visualize, you stand, you lay, and you get up and walk again, and you're more free by selecting awareness of diaphragms in lieu of skeletal chains. So it's sort of a mirror to what we were just explaining. And then there's the ABCs of sitting pain-free will be, for all of us who are working from home, taking a look at this inner ear and referencing an ergonomics from inside out at your workstation. And then there'll be a discount for virtual reality bones level 1 training when we do get a chance to travel again after this pandemic and vaccination, and certainly more worldwide ecosystem awareness of you know, all levels of biology. You know, we'll look to travel and meet again and do hands-on teaching. So those are the three.
Wonderful, wonderful. So again, you just click on the link below the video, and that's right, down there.
That's what they're doing.
And it'll take you right over there so you can get that from Tim.
Yeah.
Tim, thank you so much for contributing to the body of knowledge. We see encouraging signs that the research world is, you know, we're slowly opening up more and more into the research field in Feldenkrais and figuring out ways to get the work studied. And I think you have some interesting thoughts here. I mean, I've seen for myself that when we include skeletal teaching with people, that they do better. But this idea of really then trying to take those images and bring them much more clearly into their internal awareness sensation, really nice, very nice. I think it's a great contribution.
Right. So publication comes next. I need to work on that as part of 2021. Yeah.
Okay.
Or the journal, peer review it, all that stuff. That's all.
Yeah. You've got. There's more to do. There's always more to do. Always more to do. But you know, it's. And I just want to ask you too, Ben, about your training. Do you see that training as being a good one for body workers and physical therapists and et cetera? It's not just for Feldenkrais people, for sure.
I think anyone who touches someone to teach them is good. Certainly, it's designed around Feldenkrais, but we can't really remain in our how did my professor call it? It's not an ivory tower. He called it a fortress. It's an island fortress of a profession and discipline that has all our language and concepts and jargons and Feldy speak as we know it, right? But there's a whole world outside that can utilize what we know more accessibly. So yeah, definitely want to open it up to manual therapists, chiropractic, massage, bodywork, movement therapists of all kinds. Yeah,
great.
Somatic movement therapists.
Wonderful, wonderful. Thank you so much.
Thank you,
everybody. Just keep tuning in. We've got more.
Yeah, good stuff going on here. Yeah. All right.
Thanks, Tim.
Stay safe, everyone. Thank you. Bye-bye.
Bye-bye, everybody.
Bye-bye.